you've talked about things like indications-based pricing,
Mm-hmm.
or allowing prices to fluctuate based on the stage in which the drug's being used. Cheap price up front, if the patient gets a response, then you start to charge a more expensive price. The problem is government rules that prevent this. What do you think is the appetite for changing some of those rules, allowing more creativity in how drugs are priced?
Right. I think there's an appetite for it because I think everybody's trying to put down some milestones of how can we change drug pricing, especially on the public side. I think you're seeing a willingness from an administration. You're seeing Democrats and Republicans. This used to be kind of a partisan issue, that the Democrats kind of were anti, pharma, and what you're actually seeing now are Democrats that are saying, well, let's actually try to see how we can spur innovation, but come through with some creative pricing mechanisms within Medicare. And I think that's to me, the fact that that conversation is happening, even irrespective of the media, is an important one. Now, if they can actually deliver on that, that's a different question. But
so which way do you think the legislature would go to allow Medicare to have value-based pricing or indication-specific pricing with the threat potentially of allowing Medicare to negotiate drug prices? I think the latter would certainly reduce drug prices more, but could that be used as a wedge to?
Correct. So I think that nobody wants to see drug negotiations the way the VA can handle their drugs right now. Nobody's asked, I don't think either a Democratic Congress or a Republican Congress is willing to kind of go that far for a lot of different reasons. Mm-hmm. But I do think that the indication-based pricing or having something that seems like a little bit of a kind of a step towards something else.
I think the challenge, though, with that indication-based pricing is explaining that.
Well,
not only explaining it, but also administering it. I think
Scott and I have talked about this. It's a great idea when you take like one use case. You can kind of walk through it. It is completely different when you actually have to take what you have to do with a formulary of all sorts of indications.
Right. So I can see a 10% coinsurance if you have stage 1 or stage 4 metastatic cancer first line. But I'm sorry, you've got metastatic disease, recurrence disease, and now you're second line, and now it's going to go up to 20%. Right. I just don't see that's going to be palatable.
None of these conversations happen in a vacuum. So interestingly enough, John, I think that complexity could end up making the bundle option much more attractive down the line. Because if you end up saying, I throw my hands up, I don't want to adjudicate this complexity, I'll bundle it all in.
What about formulary design? We've seen, we talked about the move towards closed formularies. What else do you think we can expect to see with respect to formulary design? What are the changes?
5 years ago, in 2010, we put in place a dual-tier specialty formulary for cancer drugs and all other drugs, for that matter, both under the medical benefit and under the pharmacy benefit. But unfortunately, it's been undermined. I call this the law of Newtonian healthcare payment, because for every reaction, there is an equal and opposite reaction. So, the pharma increases prices, so we increase cost sharing.
Would you expect any kind of changes in what the plans are doing with respect to how they're structuring their formularies? Anything that you're seeing in the marketplace that you think could evolve?
We're seeing.
What are you seeing?
We're actually seeing plans we're seeing narrower networks, and we're actually seeing, especially on some of the exchange plans, actually going into that formulary, more of that formulary basis. The problem is in oncology, that's tougher to do, but I think what's going to sort of change some of the rubric here is, the advent of biosimilars. That, you're getting more sort of biologic competition here, and CMS is really adamant about whether that's going to destroy a nascent industry or not, but they're really adamant of putting all those under the same codes and allowing prices to be driven down and use it that way. But we're seeing on some of these plans, wherever they can, trying to put in a formulary, being really restrictive. We're actually seeing on the Medicare Advantage side, interestingly enough, a lot of denials about, sort of mainstream drugs, and so you have to fight until you finally give up, and a lot of hurdles. So we're seeing sort of a lot of bureaucratic
more
things
utilization review.
And utilization review, which creates bureaucratic hurdles. And we're also seeing, we've seen it more narrowing of networks, and therefore making sure that you're going to narrow that network to a provider you think is literally the low-cost provider.